Okay, so we wrapped up talking about blood pressure, and that's the amount of effort the heart's putting into, or the amount of force being measured, rather, that the heart is putting out in order to move blood through the blood vessels. So once again, think about a hydraulic system. Think if you had a squeeze bulb in your hand that was full of water and you had a hose attached to each side of it. Every time you squeezed it, it would force water out one tube. It would come all the way around and come back in the other tube. That's kind of what your circulatory system is. It's a big hydraulic system. If you've ever studied hydraulics, then you understand that concept. And even if you don't understand hydraulics, just think of it that way. You have this ball of water, a water balloon. There's a hose coming out each side. When you press it, it leaves one side, it goes all the way through the hose and returns to the other side. That's essentially what your heart is. The amount of force required to force that fluid through that system is your blood pressure. Not the same as your pulse. So let's say you go back to that scenario, you're squeezing that bulb and you're sending that water through the circular tube. The rate at which you press the bulb, do you do it once every 3 seconds, once every 10 seconds, once every 20 seconds? That's the tempo. That's the pulse. So when we talk about pulse, we're talking about how fast, how many beats per minute, in other words, your heart is beating. We have two important prefixes to help determine this, tachy and brady. So tachycardia is a fast heartbeat. In most humans at rest, if your heart is beating faster than 100 beats per moment, that's considered tachycardia. So the question is, are you suffering from anxiety? Are you having a reaction to something? Is this where you normally run? How you answer those questions could be determined if anything needs to happen as a result of that. But typically speaking, if you're at rest and not under stress, and your heartbeat is over 100 beats per moment, that's tachycardia. It's concerning. The other way, inversely, the other way around is bradycardia. This is a slow heartbeat. So as, once again, sitting at rest, if your heart is less than 60 beats per moment, it could mean a couple things. If you're Lance Armstrong, the cyclist, his resting pulse is about 45 beats per minute. He's not in heart failure. That's because he has such a good cardiopulmonary system. That bradycardia is kind of the state he's in. But once again, he's very healthy and his body's oxygenated. It's not fighting to get oxygen. For most of us, however, in a sitting position, if our heart is beating less than 60 beats per moment, it gets people's attention. If it gets below 40, it really gets people's attention because that could indicate heart failure. Very few of us ever go into bradycardia unless our heart has something going on with it. Tachycardia, you can induce yourself. Just get on a treadmill for 5 or 10 minutes or ride a bike. You'll be tachycardic. And if you want to measure how good your cardio conditioning is, if you can get your heartbeat up to 140 beats per minute and it drops to under 100 beats per minute within a minute, you have very good cardio training. So you're recovering really quick. The other part of this scenario, of course, is the way it's happening. So is the heart beating at regular intervals? Is it ba-boom, 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 or is it ba-boom, 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 ba-boom? So the heart should have a constant pulse, a constant rhythm, and it shouldn't alter from it very much. Every once in a while you might skip a beat, but it shouldn't be a regular thing. If it is a regular thing, you have an arrhythmia or a dysrhythmia. These are abnormal heart rhythms or irregular heartbeats. Now, we all have them from time to time, but if it's a consistent thing, it's something that needs to be looked at. You'll see in this diagram, the one on the left, we have something called the SA node. Those nuclei that I showed you earlier in the heart tissue, those little oblong purple dots, those are, as I said, nuclei, and each one of them are capable of being the boss of the heart. Now, the guy or gal who really has the job is the SA node, and you'll see him up in the right atria. They send out a signal through the heart, an electrical signal that goes down that series I told you about, the bundle branch and Purkinje fibers, and it says beat. And so if the SA node is functioning correctly, it's going to have a nice smooth tempo. That's about 60 beats per minute right there, maybe a little quicker than that. And so it sends a signal that often to the rest of the heart to tell it to beat. The trick is that all the muscle fibers have their own nuclei. So just like the SA node, any one of those nuclei may decide that they're the boss. And if they decide that, that is our dysrhythmia. So in the picture on the right, you can see the SA node is lit up. It's sending out a signal, but so are all these other cells here that should not be sending out signals. They should only be receiving them. For some reason, they've decided they're going to control the rhythm of the heart. Now we have an abnormal rhythm. So instead of this nice steady rhythm, we might have and a long pause, and then maybe 3 beats, and then maybe a pause, and then maybe a couple of beats that are normal, and then it'll stop. That's an example of a dysrhythmia. So I just illustrated to you atrial fibrillation, otherwise known as AFib. And when we talk about that, we're talking about the heart not beating regularly. It's a dangerous situation potentially because as the blood settles in the atria, even for a fraction of a second, small clots can begin to form. Small enough to get through the blood vessels, small enough to get into the brain or lungs, big enough at that point to cause problems. So AFib, we want to make sure we get it under control. One of the ways we diagnose it is an electrocardiograph, or electrocardiogram. Remember, gram's the one we threw out, but that's the old word, and I still want to use it. But we're going to use electrocardiograph. This is the instrument for recording the electrical activity of the heart. Electro, by the way, is displayed at the top. That is our combining form for electricity. And electrocardiography is the process of recording the electrical activity of the heart. We call them EKGs. Why K when cardio is spelled with a C, you might wonder? Well, the EKG was invented in Germany. I happen to have very close family members who are German. I speak German myself. I used to be fluent, kind of rough, but I still have some of those words. The word cardio, or cardiac, in German, it's the same word, but it's spelled with a K. So that's why we get the EKG from a word that really could be abbreviated as well, ECG, and you will hear people use the term ECG. And what we're doing on an electrocardiograph is we're measuring that heartbeat. And you can see that down here. There's a little picture in the lower left that shows you what the complexes are. We have the P, Q, R, S complex, S, T, and the T. Very quickly, the P is the heart repolarizing. It's getting ready to send the beat. When the beat hits, you hit the QRS complex. So Q is the beginning of the beat. R is the peak of the beat. It drops all the way down to S. That's the end part of the beat. There's a momentary, a millisecond where there's rest. And then you have the T wave to the far right. And that's where the heart is repolarizing. And then you repeat that cycle over and over again. So in that little diagram there on that graph, what you're seeing is one heartbeat. And we have 60 to 100 of those per minute times 60 minutes in an hour times 24 hours in a day times 7 days a week times 365 days a year. You can sort of calculate how many heartbeats you might have in your lifetime if you know how long you're going to live based on that alone. So it should be within that 60 to 100 beat range the whole time. Remember, there's only so many beats in the heart that you have in your lifetime, so don't waste them. Do good stuff with them. Looking at this diagram, you're seeing the positions, and for nurses and MAs, placement of EKG leads are very, very important to getting a correct reading. So here it's showing you where those leads are placed, and we use the intercostal spaces, meaning between ribs, and the costal spaces, meaning on the ribs, to locate where they go. So this is where the leads would go on a typical EKG. You see all the way over there on V6, that's in an area called the axillary, or the axilla. Axillary means pertaining to the axilla. Axillo is the combining form, and that's its location. So when you're placing leads on a patient, that V6, that's exactly where you would place it. And that's why we're giving you this word right now. Just so you know, it's a medical anatomical word to describe basically armpit, or the area just below it. And that is the axilla. Okay, so the whole thing I've been talking about, electrocardiogram, I just sort of covered it for you. EKG, ECG, either abbreviation is appropriate. It's a record of the electrical activity of the heart. It's non-invasive. It records the electrical activity of the heart, and it's a starting point for detecting cardiac problems, mainly having to do with rhythm. So it's not measuring blood pressure, it's measuring rhythm. I've hooked up thousands of patients to EKGs in my career as an MA. And a frequent question I get is, oh, you're going to shock me now. And it's like, no, we're not going to defib you. You're actually shocking me. You're sending the electricity to me, and my machine is reading it. So that's what happens in an EKG. We kind of covered it, so I won't give you any more detail on that. If we have a condition, and let's say the patient comes in and says, I get this rising feeling in my chest, and it's an abnormal rhythm, and we hook you up to an EKG, and we, sample a couple of milliseconds, thousandths of a second, we can see a lot of information in that. And that's what we do in an EKG. So let's say we run it, and we may find evidence there was an old heart attack, for instance. We can find all sorts of evidence of cardiac activity and sometimes pathology. But there are times when we'll hook up that patient and the EKG comes back perfect. But the patient says, look, I'm telling you, this happens, and it's scary, and I don't like it. Fine. We hook them up to a Holter monitor. Technology has changed, so they don't really look as much like this unit that you see in this picture anymore, but the concept is still the same. It's a small portable EKG unit. We put it on the patient for 24 hours or longer, and this provides a record of cardiac arrhythmia that would not be discovered by an EKG. So we hook you up to this. We tell you there's two things you can't do. You can't, well, yeah, two things, I guess. You can't get it wet, so you can't take a shower. And we don't want you sleeping under an electric blanket if anyone is inclined to still use something called an electric blanket. Those will mess up the readings of the Holter monitor. But this will do a 24-hour reading, and this will capture an arrhythmia that maybe we don't capture in the office. Now, usually we can get them, but not always. So this is a very useful tool to measure the heartbeat over 24 hours or longer, sometimes up to 72 hours. And then we can take a look at that record and see, was there any abnormal activity? And the question we're really asking is, was there any fibrillation? Fibrillation is an irregular random contraction of heart fibers. There's Purkinje fibers I described to you. Now they're contracting at an abnormal rate like we've been discussing, usually because of ectopic beats. And when I say ectopic, I mean the SA node is sending out its signal, but these other nuclei in the heart tissue are also sending out signals simultaneously. So those other beats are called ectopics. They're not supposed to be happening, but they are, and it's causing fibrillation. Earlier, I described the beat and the sort of the fluttering of the heart, and we talked about atrial fibrillation, or that's in other words, AFib. That's the most common and the most treatable. I've seen patients that have lived with AFib for 40 years, and they're perfectly fine. They take their medication, and it's all good. Ventricular fibrillation is a slightly different story. That is a much more dangerous situation. Because that is dealing with the abnormal beat of the ventricles and how they're pushing blood out. So AFib, I wouldn't call it benign. It is definitely something to pay attention to. Ventricular fibrillation, however, is deadly. So VFib is something that we normally wouldn't have someone walking around treating. They're probably going to be hospitalized if they have something called VFib. AFib, once again, if you've ever seen the medication ads on television, which I'm sure you have, there are lots of medications to correct AFib and to prevent blood clotting, which is the main thing that we're looking for in AFib, that you don't throw a clot when you shouldn't. A defibrillator. This is the device designed to administer a defibrillating electrical shock to restore normal sinus. So fibrillation means the heart's beating abnormally. A defibrillator is meant to stop it. There's two types. There is, we're going to go to the second one first, the ICD, the implantable cardioverter defibrillator. That's usually put in a pacemaker located in the upper left corner of the patient's chest. If you've ever seen something sticking out of someone's skin that looked like a small deck of cards, they probably have a pacemaker. Along with that, they can put a small defibrillator and they plant the wire inside of the heart. And if the heart should start beating abnormally, this device will detect it and it sends a small electrical shock that the patient will feel, and it's not dangerous to them, but it kind of just alerts the heart and it causes it to reset and hopefully into what we call a normal sinus rhythm. We want the heart to have a normal sinus rhythm, 60 to 100 beats per moment happening at regular intervals. The other is a device here on the left, and for anyone who's been trained in CPR, you probably know what you're looking at. It's an AED, automated external defibrillator. If you should run across someone who grabs their chest and falls down, they may be having a heart attack, and you might be in a sports stadium, or if we ever get out of our COVID shelter in place, you'll see these units on the wall. You see them in sports stadiums, you see them in big arenas, places where large crowds gather. You also see them in other places, like in the mall sometimes. If someone should grab their chest and drop, get a defibrillator. Look at the instructions. They're very easy. You don't need any training for this. All dignity aside, male or female, you rip that shirt open and you place those pads the way they show you in the diagram. You hit the start button and then step back. That machine will assess what's going on. If the patient needs a shock, it will deliver that shock. If you're holding the patient, you'll get the same shock. So by all means, once you put on a defibrillator, press the button, stand back, and let it go. Now, the machine might say one of two things. It'll say delivering shock, and then it'll count down, and that gives you time to get away. So if it says it, don't touch the patient. It may say, no shock needed, start CPR now. And do exactly that if you know what CPR is. If you don't, then get emergency services immediately. Hopefully you'll never have to have one of these or never have to use one of these, but if you do, you may save a life. I'm going to pause it there. I'll be right back in a few moments to talk about some other procedures we do to discover cardiac pathology. Be right back.